Hi, this is Dr. Kavanaugh coming to you from RWCS 2019. A lot of great lectures, and I was pleased to be part of it. And I got to talk on psoriatic arthritis and do the year in review. And boy, what a challenge that was. An incredible year in psoriatic arthritis. A lot of good new information. Big study was the SEAM study, which we've really eagerly awaited. This is a study of methotrexate, a TNF inhibitor, in this case etanercept, or the combination. We know in rheumatoid arthritis that the TNF inhibitor methotrexate are certainly additive, if not synergistic, and that's the gold standard of treatment. And I think a lot of us, and I would say myself included, had assumed that we would see in psoriatic arthritis as well, certainly for the peripheral arthritis, a clinical benefit, but certainly a radiographic benefit. The SEAM results were very interesting, therefore. They showed that etanercept and etanercept plus methotrexate were better than methotrexate, but there was really no synergy. So it didn't seem like the methotrexate added anything. Also, the methotrexate did not do badly. Now in this study there was no placebo, but the rates of response for peripheral arthritis, for skin, for dactylitis, for enthesitis, all looked as if methotrexate can be effective. So it's actually reasonable studies suggest that methotrexate should remain in our therapeutic armamentarium for psoriatic arthritis. Big year for biologic agents. The TNF inhibitors continue to be the go-to biologic agent. There was a sub-analysis of a study of golimumab that showed that, as in RA, you get the X-ray benefit dissociated from clinical response. So even people who didn't have the best clinical response still had X-ray benefits. For the 1223 inhibitor, there's some interesting data showing that it can be effective in enthesitis. We know it's effective in skin. We know it's effective in peripheral arthritis, not effective in the spine. And I think we'll hear from Dr. Ruderman about the failure of the ustekinumab in ankylosing spondylitis. IL-17 inhibitors, we have secukinumab and ixekizumab. The new kid on the block, if you will, is bimekizumab, which blocks IL-17A as those other compounds do, but also IL-17F. So we'll have to see if there are differences in safety and efficacy among those compounds. A lot of data, and I think we're continuing to learn from these targeted studies using specific therapies. We're learning about the diseases themselves. So really a bedside to bench approach. Very exciting, and we look forward to more developments in the year to come.